I'm Sarah. I'm a senior clinical therapist with BMed. I'm so used to introducing myself with SBIRT, saying like, "Hi, I'm Sarah. I'm a clinical therapist with the trauma team." And so that's why I hesitated because SBIRT, I work SBIRT with the trauma team at Ruby Memorial Hospital. So I'm going to talk a little bit about what that is. And so SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. Next slide. I have no conflicts of interest, no financial gains. And as always, I'm going to have the Animal Friends of North Central West Virginia join us today for a few animals that are up for adoption. I double checked this morning and everybody was still on their website. So everybody's up to date and available as of 8 o'clock this morning. So next slide. And Park Ranger Trout is our first one up. So like I said earlier, SBIRT has three different parts. So it's the screening, the brief intervention, and referral to treatment. And so obviously, our beautiful SAMHSA has standards and advice towards setting up SBIRT screening because SBIRT really can kind of fit into everywhere. And it's one of those things that is so helpful and able to kind of engage in a way with people who even might be hesitant to engage. Um, SAMHSA has the suggestion, it's called TAP 33. There's going to be a link at the end of it if you're interested in setting up SBIRT programs or incorporating that into your practice already. So with SBIRT, there is definitely different styles of engagement that we kind of have to work in. So you have to really have a different way of thinking for things because it is coming in three parts. And a lot of times, you're starting to engage. This might be the very first time that this person has ever engaged with anybody who works in mental health, let alone like it might be the first time that they're actively talking about their substance use, talking about mental illness. And so, like, you kind of know a little bit, do a little bit of digging before you kind of come in. How I approach somebody who's a veteran is very different than how I'm going to approach an 89-year-old woman who just broke her hip. Um, and so you have to be a little bit flexible with styles. And, as you kind of do SBIRT more and more, you kind of have like this flow chart style of thinking. So, like, you just kind of have to kind of check the boxes and get used to it. And I've been doing it for so long. I've worked with SBIRT team for over 6 years now, and I've been doing it so long that it's kind of second nature to me. So the more you do it, the better you get at it, and the more it just kind of becomes a flow. But and each person has their own style with it, and so like the more you practice it, the easier it kind of gets, and the more comfortable you get with kind of using SBIRT. So our first animal is Park Ranger Trout. Park Ranger Trout, based on, Animal Friends website, said that he was lost in Cooper's Rock. And they found him and he was in rough shape, but now he's starting to get better and he's available for adoption. So next slide. So why do we do SBIRT? Like I said, a lot of people that I kind of encounter while doing SBIRT, it might be the very first time they've ever talked to a therapist or ever engaged with somebody who is in the mental health field, or even this might be the first time that they ever even talk about substance use or problematic things. And so, like, this really helps us to start a conversation and engage in a way that we might help motivate people to get the treatment or get the help or even plant the seeds for maybe them to come back later. So this really helps us to spread knowledge and awareness, not necessarily to the people that you might be doing referrals like using SBIRT on, but it also if there's family involved or if there's other people that that person cares about, like this might also be the first time that their eyes are opening to some things that might be a problem. Another thing that it really, really helps us is there's a lot of data collected when we do SBIRT, and we'll get into this later, but there's a lot of data that we collect, and we can use that data to kind of look at needs assessment or how to advocate. And this is not just, with the staff, but this is also like with our staff that we might interact with, but on a community basis. And one of the examples that I have is when when I first started working with SBIRT, we started to track how many people got in accidents with ATVs. And that enabled us to start a program where an injury specialist kind of comes in and talks to people who have been in ATV accidents and talks about the importance of wearing a helmet, or even like with our children's side of it, they'll give children new helmets, or they'll kind of work even with car accidents. They'll work with the families who might have had a car accident and their car seat might have become damaged, and so they kind of go in and say, hey, here's this new car seat, or here's a voucher to go get a car seat. And so, like, because it's not that easy just to replace a car seat after a car accident. And on top of it, like, through all the other things that go into having a car accident. And so, like, by the data that we were able to collect with SBIRT over the years, we have been able to kind of turn it into something that's really, really important. And I'll kind of, that kind of connects to the National Survey on Drug Use and Health and Mental Health. Um, so the overall thing. So this is based on 2024. 2025 has not come out yet. That'll probably come out in September. But what kind of happened with the most recent data from the SAMHSA survey is that what we're doing is actually working, not what just experts doing, and not like what we're doing as a mental health community, what we're doing as people who talk about substance use, what we're doing is working, because there hasn't it's either decreased or there's been no change in adolescents and adults for substance use and mental health. So that means it's either getting better or it's staying the same. So it's not getting worse, except for unfortunately vaping and adult suicide planning. But even then, the fact that a lot of adults haven't gone through with it, that means that we're disseminating the knowledge for 988. That means we're disseminating the knowledge to have people kind of stop in those planning stages. So what we're doing is actually working, it seems like. And so, like, they also looked at people who are 18 and older that have identified having like a problematic substance use, or even problematic like use of pornography or use of gambling. And 73%, and like within their lifetime, they've identified that they've had like addictive behaviors or addiction kind of use. 70 74% identified that they were in recovery. So that's pretty significant. And the same kind of goes with 18 and older, of people who have identified having mental life issues within their lifetime. 66% have identified that they're in recovery because of that. And so what we're doing is working. And so this is kind of proof that we can kind of keep the ball rolling and hopefully keep getting better and keep healing people, which is, kind of why we all got into this. Um, so another great thing about SBIRT is that it is something that we can kind of go in and get it done fast. It's kind of a fast, quick, engaging conversation. And like I said, it also gives us the opportunity to plant those seeds for how things might be a problem or how things might not be a problem. And it also, kind of destigmatizes mental health, because if we go in and we're open people and we start that conversation, that kind of dispels that old thinking of like, oh, therapy is just for people who have major problems, or all the stigma that kind of goes with healing the mental health in that mental health process. So assessments are a bit longer and they're a bit more detailed, and so sometimes people are a little more hesitant when it comes in, oh, I'm doing this assessment. So expert kind of makes it like a little bit faster and a little bit more like a conversation. Especially the more comfortable you get with it, the more kind of flow that you find with yourself as you engage with new people and different people as it goes on. as you go on and engage with different people throughout our careers. So SBIRT is also very like I said, there's Sam says standards for it. And so all of this is evidence-based. All of this is saying like the engagement is helping people, the way that we're able to kind of collect that data and help the community, the way that we're able to kind of help engage people and start that process of healing, especially, as they start their journey towards recovery or as they start their journey towards healing after a trauma or an accident or anything like that. So next slide, please. And if there's any questions, please ask away. Ask away. I talk a lot and I know this stuff fairly well. So do not hesitate to ask away. So so we have two kind of parts towards our SBIRT and what we kind of do with Ruby, with the John Michael Moore Trauma Center. And so we have it broken down into 2 sections. We do screening for 17 and up, and then we have screenings from 12 to 17. For a level 1 trauma center, which is what the John Michael Moore Trauma Center is, for being a level 1 trauma center, we have to meet or at least have 1,200 traumatic cases come in. That's in order to kind of be labeled a level 1 trauma center. We also have to have certain standards in place, like we have to have a medical ICU, we have to have a surgery ICU, we have to have a cardiac ICU, we have to have there's another ICU, neurological ICU, and we also have to have therapists on the trauma team that kind of come in and talk, and SBIRT is one of those things that we engage. And so when they were setting up the trauma center, they incorporated from the get-go like the SBIRT service, and I think they started the trauma service, I want to say in 2015 they started the trauma service. And so like we were kind of incorporated from the get-go. And so there's a lot that goes into determining whether or not somebody's kind of seeable. And so obviously we want that person to be oriented. We want that person to know, what day it is, who they are, those kinds of things. We also want them to be medically stable. We can't go see people who are intubated and have no way to communicate. We want to make sure that that person's, not throwing things or restrained or anything like that. And so we want to make sure that somebody's seeable. Part of the people that we definitely don't see are protected populations. So people who might have a cognitive disability, people who might be incarcerated, even though those people really, really need help because they're in state custody, we're kind of limited on what we can do and how we can help. And so one of the first things we do, let me grab I brought a packet with me. And so this is kind of the packet that this is kind of the packet, and I'll go over this, but this is the packet that we kind of go in with, just kind of like a brief thing to kind of start this process. And so one of the first things we do is we give a general health history questionnaire, and the links to all of this is I have a resources page. So the links to all of this is in there. And so basically what we do, we kind of modify a lot of this stuff to help our population and to help kind of engage our population. And so because we've been doing this for so long, we've kind of had to figure out our own way, because even though it feels like 2015 was like not that long ago, it kind of was. Um, so I'm still under the notion that the 90s was like 10 years ago. So it really is kind of surprising sometimes to go back and look. So when we started seeing people on SBIRT with the trauma service, we kind of modified our own adult health history questionnaire. So this is kind of the thing that we kind of came up with a while ago. And so it's just yes or no questions like, in the last 6 months, have you been feeling down, depressed, anxious, hopeless, anything like that? Have you had 3 or more drinks in one day in the last 6 months? Have you overtaken prescription medications? Have you used any sort of illicit substances other than those required for medical reasons? And that's been a little bit tricky too, because we've had to kind of modify how we talk about marijuana in particular because of the way that it's kind of changed within our culture. And so like the AHHQ is kind of the buy-in. That's where you go in and just kind of like conversation and kind of keep it jovial and kind of keep it, relatively like you have to be able to read the room and read the room quickly. And so like this is part of my favorite part of my the favorite part of my job because you do have to think quickly. You do have to think on your feet. And so like having that variety and the variety of people that you meet and you might have an 89-year-old woman that says, yes, I've been hopeless. I just fell down for the fifth time. And so like just learning how to support that person, or like, yes, I'm anxious. I was just diagnosed with cancer. Or my husband died 3 years ago and I've never been able to kind of deal with it, or I'm still sad about that. And so like it does take a very nuanced approach to kind of start that conversation and start, you know, acknowledging that number one, it's scary as hell to be in a hospital after the accident. And so, like, just having that fluidity and being able to navigate it based on the setting that you're kind of implementing expert in, it's making sure that you feel confident and you feel like you can go in and start these conversations because after all, this is what we've been trained for. This is what, having these conversations and being able to read people, this is what we've been educated for. This is our careers. This is our livelihood. And so being able to trust in ourselves to kind of do that thing and to be there for somebody in a very vulnerable situation, and acknowledging that, yes, there might be a very unique power dynamic in it, but knowing that we're being there and being there with for people without judgments. And so just kind of not judging, not making it an awkward situation, just kind of allowing it to be you being a person, being there for somebody else, and also being grateful that they allow us to be there for them. So. So once we kind of do the adult history questionnaire, one of the things, if they did answer yes to like any alcohol, smoking, substance use, we do the assist screen, which we can kind of say like some of the questions are like, how often have you used in the last 3 months? How often has it caused any social problems? How often? And it's just the typical assist screen that we all use. And so, the typical assist screen that we've all used in our lifetime, if we've ever kind of used it. And so it's just basically like, has it ever led to any social problems? Have you ever kind of failed to do what's expected of you? Have you ever tried to stop in your lifetime? Has any of your loved ones ever said, like, I think you should stop drinking so much? And so based on those questions, we kind of look at, if there is an intervention that's necessary. And luckily on the back of our assist score, we do have a handy dandy sheet that tells us when to do an intervention and when not to do an intervention based on the score they get. And so once you're doing this long enough, you can kind of incorporate that and you can adapt. The beauty of SBIRT is you can adapt the screening to include whatever you want. And so, like, it's just a making sure that we give them information. And so, like, we can say, like, I noticed that you scored a 4 when using cannabis. Like, I noticed that you feel like there have been some times where you haven't been able to fulfill the things that are necessary in your life. And so you can kind of start a conversation with that, or even like, plant the seeds, because one of the major things I kind of get to intervene with, and this will kind of come a little later with intervention, is, I get to say, hey, your blood alcohol level was XYZ, or your urine drug screen had this in it. And so like I get to kind of start having that conversation. So another thing that we use is our PHQ-9, which is our depression screening, which most people are familiar with. It is the typical, like, in the last 2 weeks, have you had little pleasure? It's again our typical PHQ-9, which most of us know what it is. So have you ever had little interest in doing things like most of the day, nearly every day, several days, or not at all? And it just kind of goes through the list, like, have you been feeling tired or had a little energy? no, like a limited appetite. Have you ever thought about yourself being dead? And so this is also on top of the safety assessment that most people kind of do or incorporate. So like this is just kind of what we've incorporated with our SBIRT service. But again, the beauty about screening is there's a crap ton of them, and we can kind of incorporate a bunch of different ones. Another one that we do incorporate is the PTSD screen. And so this is one that is specifically another one that we specifically designed for our SBIRT service. It says West Virginia SBIRT, but we were kind of one of the early ones in there. Um, and so like that's just talking about nightmares or, trying hard to think about the way that we avoid things. And, if the person is over 70, we like to incorporate the geriatric depression scales. And that's another one that says like, have you been satisfied with your life over the past week? Have you dropped any activities? And this one I feel like is a little bit nuanced because it does ask like, do you feel like your situation's hopeless, or you know, are are you feeling pretty worthless the way that you are? Are you full of energy? And so like it's kind of nuanced in the hospital setting because they're in the hospital setting. So of course they're gonna feel like not so great because they're in the hospital and they're hurt. And there's not a lot of people that are excited about that. And so we have to be a little bit nuanced with it. So we have to kind of look at, kind of talk to them and look at it in that context of like, is this something you normally feel, or is this because of the accident? And if it is, even if it is because of the accident, we can still do an intervention on that. And so, like, there's so much that the screening can tell us, and that's why you kind of have to work and modify it based on what the needs are for your practice. So, and obviously Suki's here, so she's up for adoption. Next slide, please. So, this is where, like I said, we have to see 80% of everybody that comes in on the trauma service, and that includes from 12 to 16. When there's not a lot of people who come in that are 12 to 16, missing a kid is a really, really, really big deal. And we see, 12 because 12 to 16 because that is considered adolescent. Children need something a little bit different. And so Ruby Memorial Hospital is a level 2 pediatric trauma center, because we just don't have the stuff that really makes us to get to level 1 as of right now. And so with children, again, we don't see people who are in kind of a protective custody situation. We don't see people under 12. We do have another person. Her name is Courtney, and she's kind of on the trauma service peripherally, and she sees people 12 and under. We do see children that are in the emergency room from 12 to 16. With adults, we do not. We don't see them unless they're actually in the part of the emergency room that means that they're going to be admitted. And so we also have to modify our screenings for our adolescents. And one of the things that we kind of have to be really transparent with is that we are mandated reporters. And so, like, if a child comes in with a blood alcohol level, we still have to mandate report that. If it wasn't mandated reported before us, if it wasn't reported to CPS before us, and that's stuff that has to be documented within their chart. So we had to modify. We have like a primary care evaluation about mental health disorders, and so we go farther by saying like during the last year, have you been feeling depressed or down or anything like that? And so we talk about like, have you had little interest in doing stuff? And then we also incorporated the craft too. And so the craft is really just like do you use when you're driving? Do you use to relax? Do you use when you're alone? Do you often forget if you've been under the influence of alcohol or drugs? And so we assess like substance use, and we go again for the past year because with children it's a little bit different. And so that's when we have that opportunity to do a lot of psychoeducation and interventions. And again, with children, you can use any of the other kind of screening tools to help you get more information, like PTSD, like the PHQ-9. Like there's other things that you can kind of use, but we found that the craft and like this modified screening that we've kind of made has been really, really effective for us. And that's one of the reasons that we have been able to advocate to get like helmets for kids that have car accidents, or because all too often we found that people were reusing like helmets, for example. And we know that once you have an accident in a car or an accident on your bicycle and you hit your head, like that helmet is no longer as effective as it was if it before the accident. And so we've seen a significant increase in e-bike accidents. And so all too often people just reuse the helmet, and that just puts us at a higher risk. And so it's good to kind of it allowed us to advocate for that kind of service to be integrated within our hospital. So Maggie is also up for adoption. She is a special needs dog. She has allergies, and so they've Animal Friends in North Central West Virginia has definitely been able to kind of get her under control based on what they said on their website. And so she's looking for an adopter too. So, next slide. Any questions so far? I do talk a lot and I talk fast. So, all right. So our brief intervention. So this is one of my favorite parts because I get to say like all the knowledge I've gathered over the years and all the things and all the little booklets and all the little things that I've accumulated over my years, like from sex trafficking to suicidal intervention to rethinking your drinking to every little packet that I get or little booklet that I get or pamphlet that I get when I go to those wonderful conferences that are out there. I make sure that I give those out. So and replenish them. And so everybody on our team definitely uses all of that. So we do the assessment, we do the screening, and so like we're ideally we want them to kind of rethink things that are problematic in their life. Um, but sometimes we have to meet people where they are. And so a lot of times I'll have somebody come on my service that might have a blood alcohol level of 350. And so I have to go to them and say, like, hey, we don't consider you medically stable if you're above 300. And so I get to have that conversation, or like, you were driving your car when your alcohol level was that high, or you were driving your car and you nodded out because you were using a substance, or, whatever the intervention might be. And so, like, it does hopefully open their eyes a little bit, but sometimes people are like, nope, it's not a problem. And that's okay that they're in that pre-contemplation stage. Eventually, hopefully they kind of navigate the stages of change and recognize that it might be a problem, but we can only go so far. And so like that's where we can use psycho education, disseminate that information, like use that knowledge of substance use and substance use trends, and also be aware of the cultural impacts that it might have. And so like when I kind of have like we have to stay on top of different things, and one of the trends I saw way early on, and I've talked to Tony about this, Tony DiCiacchio, I don't know if she's on here or not, a whole bunch about the trends that I noticed with marijuana before it was even kind of like common knowledge. And one of the major trends that I've noticed with it years and years ago was that marijuana, as soon as it became like legalized for medical use in West Virginia, almost as soon as it became recognized, like able to have that, I noticed that people who claimed that they were only smoking marijuana had other substances in their system. And so it was almost instantaneous back in 2020 or 2021, whenever that happened. It was almost instantaneous that people were also having other things in their system. And that's where we kind of recognize that it's being laced with things in order to kind of keep up with the levels of CB or THC that are being sold in the dispensaries. And so like we have to stay on top of that, but we also have to notice our trends ourselves sometimes too. And we can raise awareness to a certain extent, but like it does kind of catch up with us where it's just kind of like, make sure you buy from a dispensary because of X, Y, and Z. And so like making sure that we stay on top of this stuff and like also recognizing because we are a level one trauma center and there's a lot of highways around here, we have to recognize that somebody from, Morgantown, West Virginia is going to be have a different kind of perspective from versus somebody who's from Iowa. And so, like, we do see a lot of different people, especially traveling through, or people who are, you know, in West Virginia for work, or even Pennsylvania. Like, even though it's just like a couple miles north, just the treatment difference between people and what their goals are, what their morals are, and so like there is a vast difference between the two. So we have to really be aware of that kind of stuff. So when we do our brief interventions, and so like we can go in and say like, for instance, that we know that, if somebody might be in a domestic violence situation, like having that cultural awareness of what might go on with that, and also having that awareness of like, you know, that person who did that might, if I give her a packet or if I give them a packet, they might see that abuser might see that when she goes home, and it might not end well for her. It might not go well for that person. And so like even just being aware of like the cultural aspects of that. Um, and so it does take a little bit of awareness, and like I said, like you have to kind of be fast on your feet and almost think like a flow chart. So um we have a whole big binder that we kind of carry around the hospital full of information. And on the back of we have a card specifically designed for us. And on the back of every card, it has phone numbers and links to different kind of services, like 988 for one, the domestic violence hotline. It has veteran suicide hotline. Like there's a bunch of different information, even on the back of our little card. So. All right, so the referral treatment, our last little step. So this is where we talk about like inpatient treatment versus outpatient treatment. If the person's feeling suicidal, we're definitely going to recommend inpatient treatment, or I'm going to make sure that the team knows that it would be important, like the trauma service knows that it's important to engage and tap in the full psychiatric consult team. And or if they feel like they have a problem with alcohol or benzodiazepine use, I can say like, hey, that's a withdrawal you can definitely die from. So let's get you into treatment. Let's see what we can kind of do. And so like it's that balance of like inpatient versus outpatient treatment. And you know, I might recommend inpatient treatment because, they have, complicated withdrawal history, or, whatever is kind of going on, and they only want to do outpatient treatment. I can still suggest they do that, but ultimately people are going to do what people are going to do. I'm going to tell them like, hey, I'm going to tap in the site consult team because I think you should do this. Like ultimately it's up to the person because we all have autonomy. Um, that still doesn't, if I recommend inpatient, that still doesn't mean I'm not going to give them outpatient information as well. And so like making sure that I suggest to them what I think they should do, but making sure that they have the options to make the most informed decision, because ultimately it is their decision versus my recommendation. And so like one of the problems that we do come with, that does come with outpatient treatment, is that it's not always accessible, as we well know. Even though like COVID really did help us expand our telehealth, insurance is a very tricky thing to navigate, especially when we're on the border like we are. So what is accessible to somebody in Pennsylvania might not be accessible to West Virginia and vice versa. And so like I recently met a female who was on a motorcycle and intoxicated, and she would have been like, it really like her life. I've met with her a few times. It really, she really seemed motivated for getting better and motivated for treatment and all these other things. But she had Pennsylvania Medicaid, and so like I was thinking like, oh my goodness, this person would be perfect for our DBT addiction treatment program, and she was ready for it. And then I explained all of it, and then I explained what it was, like we talked about it, and then I realized that she had Pennsylvania insurance, and it was just kind of like, oh, dang it. Um, and so because we can't at work, we can't at BMed, we can't bill WV or Pennsylvania Medicaid, we were unable to kind of get her in that program. However, I was able to kind of look at other DBP programs that she was interested in and kind of look at different options for her to hopefully get her on the right path to recovery and healing, because it's not just, the mental healing, it's the physical healing. And she has a long road in front of her. Um, so we also want to make sure that there's appropriate levels of treatment. If somebody's not going to engage with an IOP program, then again, it's not going to do the provider or the person any benefit if I refer them to something that they're not going to attend. And so wanting to make sure that, like, I recommend this, but if you're going to do this, like, that is what you're going to do. And so, like, making sure that I'm giving appropriate levels of treatment for their area, because they also might have issues with transportation or, whatever kind of might be the hurdles in their way. And the next level we have is we do have a trauma support group that's associated with our trauma service. And so, like, that's a Zoom meeting that meets, I want to say, the first and third Thursday of every month, but that might be off. I can't remember off the top of my head. But every person that comes in on the trauma service gets this in their discharge information. And then finally, we have like peer and community support groups if that's what they want to do. There's been plenty of people that are like, no, this was just one relapse. I'm going to get back to my meetings. Like, I already know what to do. Like, this happened. And so, one of the really cool things about working with our trauma service and the SBIRT team is that we get to kind of follow people that we meet on the trauma service if we want. So I've had, I think, 5 people that have met through the trauma service that I've taken on as my own into my own caseload. And that, also works with people that are also seen within, BMed or within WVU medicine, because I can shoot a message to that provider and say, hey, I met this person on the trauma service I through SBIRT. Like, I just wanted to send a message to give you a heads up so that provider's also kind of aware of the situation before they meet with them next time. Or, that also gives the opportunity for that provider to think like, well, maybe they need more support. And that literally just happened this past week. So being able to kind of have that connection and that warm handoff really, really does make a big difference. So, fine. So I talked a lot about trauma service at Ruby. So these are the results of everybody we've seen in 2005 or 2025. I told you. I swear it was only like 10 years ago. So this was 2025. These are our all results. So this is what we kind of monitor right now. And so, like, for instance, in January, we saw 97 people that were negative. So that's basically like, no, I don't have any mental illness. No, I don't drink 3 or more drinks. No, I don't overuse my prescription medication. And no, I don't use illicit substances. So that's completely negative. BI for mental health means that I had a brief intervention, or we had a brief intervention based, and we talked about mental health. And that's including, you know, letting people know what trauma symptoms they might have after a car accident, what trauma symptoms they might have after a tractor rollover, or after they've been shot, or after, whatever kind of brought them in, what they might have to navigate. And that even includes like talking to them, like if they were in a car accident and the other person in the vehicle died. And so having a conversation with that person, or, if it was a parent who lost their child in an accident, or, whatever it might be, or even a child that lost their parent in an accident. So just like making them aware that there are options and there are treatments for that. Um, Brief intervention for substance use. Then we have treatment for both, a brief intervention for mental health and substance use. And then we monitor how many times we've done a follow-up or a referral for that person. And so you notice that we only saw 112 kids in 2025. We did meet our quota. in order to maintain that certification, but it's still really, really hard to kind of get kids because it is so new. The children's hospital is so new, but children just don't get it as much as adults do. So our team is a very diverse team, and we have some very, very smart and experienced clinicians. So our lead is Caitlin Hanna. She runs the entire kind of SBIRT team. And so we have to make sure every single day is covered by somebody. So that's Christmases, every single holiday, every weekend, every single day is covered by somebody on the SBIRT service, every single day. And so we have children therapists on our team, or adolescent therapists on our team. We have adult therapists on our team. We have I'm the veteran on the team. Um, we have people of color on the team, so that engagement and representation does mean a lot and does help with engagement. So we do have a lot of variety and experience that come with our team. So there's only 100 trauma level one trauma centers in the nation, and Ruby Memorial Hospital is one of them. Like I said, we're level one adult, level two child or children, and we are a military training point for the National Guard, West Virginia National Guard Special Forces. And so like that means that they can come and get trained with our trauma service to kind of, you know, be better at their jobs. We have gotten a little bit of recognition over the years because SBIRT, I feel lately, SBIRT has definitely come into like the mental health zeitgeist. And so we have had a little bit of recognition. And like I said, we've been doing this since 2015. So we have been able to kind of train other programs and to kind of advocate and help other hospitals advocate and get trained up. So we've been doing pretty good. So next slide. So we have some obstacles, obviously, like insurance is an obstacle, resources like transportation, the stigma, the time it does take, because sometimes we're limited. Sometimes we have to see, you know, 15 people and we only do half a day of it. Our service is only available from 8 to 11. And so like we have a lot of people to see in certain amounts of time. And we can only see people 3 times when they're in the hospital. So we can only bill 3 times for 3 different visits. Now the length can kind of vary. The length of actually seeing somebody can vary, but we also have to make sure that we see everybody. So it is a balance. Um, Sometimes it's hard because other providers will come in the middle of you asking their questions or the middle of you talking about like this tragic accident where they lost their spouse and you know a doctor might come in and be like, let me check your eyes, and it's just like, oh, wait a minute here, we're talking about some pretty big stuff. So being trauma informed is definitely a way that we can grow. Also, training. Not a lot of people have had a lot of training in expert, and so some of the ways we can kind of overcome them is getting trained, implement expert when possible, getting a license in multiple states, make connections within the community. We might be, you know, I might have my caseload full, but maybe if I talk to Derek and he's like, no, I have space on my caseload, I can be like, hey, you know, I'm full, but I know this great clinician that would be able to kind of take him on. Um, just make sure that we talk to our lawmakers to increase resources and, you know, using the information that we gather to advocate for our services because we keep this entire packet for 3 years. So every 4 years we have to get recertified. And of course, this year's a recertification year. So yay. Um, so so that's why I'm able to have the numbers so quickly. Um, so kind of doing these and implementing these things are very, very, very helpful. It does take a little bit to find our kind of flow with it, but it's worthwhile. So next slide. These are the resources that I was talking about earlier. So West Virginia, WVU has an expert training for free, and they give you CE credits. So we love some free CE credits. So I'm all about that. So SAMHSA has their expert guide, and The American, so the group that kind of certifies like a level one trauma center, level two is the American College of Surgeons. I forgot to mention that earlier. They have a whole trauma education section and it's phenomenal. So the American College of Surgeons, and that's what that link is for. So next slide. So these are all my citations that I talk about. So any questions, comments, concerns, anything? Oh, and I missed that last Pat. That was Kendall Dashian, I think. Yeah, so she's up for adoption too. So, all right, any questions?